So the cavernous sinus is a dural envelope which contains the cavernous segment of the ICA, which you saw, and it's a venous confluence of several veins. That includes the veins from the orbit, the superior and inferior orbital ophthalmic veins, the Sylvian fissure, that is the superficial and deep superficial middle cerebral vein, the anterocranial fossa, middle cranial fossa, basilar venous plexus, superior petrosal sinus, inferior petrosal sinus, and intercavernous sinuses, anterior and posterior. Then it's boat shaped. It's like the keel is at the posterior margin of the superior orbital fissure, and the broad bow or the posterior wall is located lateral to the dorsum sella above the petrous apex. It has a roof, lateral wall, a medial wall, and a posterior wall, and a thin inferior edge. So if you look from the side, this is the cavernous sinus, this is the anterior clinoid process, ICA, which comes out medial to the cavernous sinus, optic nerve, third nerve under the 10th margin, entering the wall of the superior wall of the inferior sinus, fourth nerve, and cranial nerve fifth. This is the porous trigeminous and Meckel's cave. So it extends from the superior orbital fissure up to the lateral edge of the dorsum sella. So this is the extent. It is applied against the posterior margin of the superior orbital fissure. These are the veins which are shown: the Sylvian vein, foramen rotundum, sphenoid emissary vein, vein of foramen ovale, vein of foramen spinosum. These are all called as the pericavernous venous plexus, which keep entering the cavernous sinus. And the posterior limit is from the lateral edge of the dorsum sella to the petrous apex, where the trigeminal impression begins. So this is the paraclival fissure. The sixth nerve enters the cavernous sinus here under Dorier's canal via the petrosphenoid ligament, and here you have the petrolingual ligament. So this is the carotid canal. So it comes, carotid artery comes here and then enters the cavernous sinus. So roof, if you see superior view, there are two triangles. This is the posterior petroclinoid fold, anterior petroclinoid fold. Both are from petrous apex to posterior clinoid process and anterior clinoid process. And then you have the interclinoid fold where the third nerve enters, and at this corner, junction between the superior wall and the lateral wall, the fourth nerve enters the roof of the cavernous sinus. So this is the oculomotor triangle. The clinoidal triangle is covered by the clinoid process. So once you remove the clinoid process, you see the clinoid triangle. Roof, if you see from the lateral wall, the tentorial edge actually covers it. So it is medial and inferior to the tentorial edge. It's difficult to see from the side. The cranial third nerve entering the roof of the cavernous sinus. I told you about the cisterns. The cisterns follow the third and fourth nerve. That's how you can open the oculomotor porus, the trochlear porus, and follow the nerves into the lateral wall of the cavernous sinus. So the cisterns enter it. So just under the tip of the clinoid process, they become enmeshed with the wall of the cavernous sinus. So if you open this, you don't actually enter the cavernous sinus, this cistern. So only where it becomes enmeshed, if you open the thin wall of the cavernous sinus, you will enter the venous space. Same thing with the trigeminal cistern. It covers at least 2/3 of the Meckel's cave. So the dura has been stripped over the roof of the optic nerve, the clinoid process, anterior, posterior petroclinoid, interclinoid fold. And if you see the lesser wing, the clinoid process is at the medial end. It terminates in the clinoid process. But the lesser wing has two roots. It has the anterior root and the posterior root. Posterior root is the optic strut, which separates the optic foramen or optic canal from the superior orbital fissure. So you see this superior orbital fissure, optic strut, roof. So the distal ring is formed by dura from the upper surface of the clinoid process. Under surface of the clinoid process is the proximal ring. So they attach to the carotid arteries to form the clinoidal segment of the carotid artery. Again the upper surface dura from the clinoid process forms the falciform ligament. You see the ophthalmic artery originates from the interdural segment generally of the carotid artery and enters the optic canal. It comes out of the dura as soon as it enters the orbit and goes to the lateral side of the optic nerve. Here it is underneath in the intracranial portion and within the optic sheath. So once you remove the clinoid process, you see the third nerve going just under the edge of the inferior surface dura, and then you have the carotid collar, the clinoidal triangle, distal ring, proximal ring, and the segment which is the pericavernous venous plexus. And if you remove pericarotid, if you remove that dural layer, you see the carotid artery of the clinoidal segment. Usually we don't do that because there will be brisk bleeding, but this will be controlled by Surgicel easily. So this is the oculomotor triangle, clinoidal triangle in the roof, the optic nerve, and this is the sella with the pituitary gland. So when you remove the dura from the roof and lateral wall and clear the venous spaces, you see the oculomotor nerve, the fourth nerve, and the V1. They are all converging at the superior orbital fissure. They form the triangles in the roof and the lateral wall. The oculomotor triangle which is in the roof, you can't see that because the dura has been removed. This is the supratrochlear, infratrochlear. Between V1 and V2 is the anteromedial. Between V2 and V3 is the anterolateral. Behind that is posterolateral Glasscock's. And medial to the GSPN, this is the carotid artery, is the posterior medial triangle of Kawase. And then you have two more. So you have two in the roof, 1, 2 in the lateral wall. So 4 in the cavernous sinus proper. You have in the middle fossa 1, 2, 3, 4. So 4 plus 4 is 8. Then you have two more triangles behind at the posterior wall, posterolateral and posteromedial triangle. So when you retract, you see the lateral wall through the roof, you see the numerous ostia of all the veins entering the cavernous sinus. So there is two types of theories. One, it is a single space, and second, all these veins, confluence of veins, they have their own distinct blood flow. The blood doesn't merge. So it's a conglomeration of veins is according to one theory. One theory says it's a trabeculated cavernous space. And this is the anterior inferior venous space in front of the anterior genu of the cavernous sinus. Above the posterior genu is the superior venous space, and medial to the carotid artery is the medial venous space. So three venous spaces are there in the cavernous sinus. So the clinoidal triangle has three parts. Anteriormost part is the triangular optic strut. This is the optic nerve. So this is the broad posterior surface of the optic strut against which the anterior genu rests. And then the middle part of the clinoidal segment is the clinoidal artery itself, the carotid artery. And the posterior part is the thin roof formed by the carotid-oculomotor membrane. So you have the proximal ring, that extends between that and the third nerve. There is a thin membrane which extends to the carotid artery. That is what forms the carotid collar. So that's also called as the carotid-oculomotor membrane. So you have three parts: optic strut, artery, and the thin membrane which forms the roof, and then you have the oculomotor triangle. If you remove the optic strut, you enter the sphenoid sinus through the opticocarotid recess. This is the clinoid segment, and this is the thin roof there. So we were talking about the two spaces of the cavernous sinus, and we talked about the carotid-oculomotor membrane, which extends from the proximal ring, carotid collar. This is the carotid venous space, pericarotid venous space of the clinoidal segment, which communicates with the anterior superior. This is the posterior inferior space, posterior inferior venous space of the cavernous sinus, anterior superior. So these are all repetitions of the same thing. You can separate the proximal ring easily from the carotid artery and elevate the carotid collar because it's not adherent to the carotid artery. However, you can do that only till the distal ring. At the distal ring, it merges with the wall of the carotid artery. So if you want to unlock it, you can do it by leaving a small cuff of the distal dural ring attached to the artery. It's easy to do it on the lateral side. When you want to do it on the medial side, you have to remove the optic strut completely, otherwise you won't have the space to cut the distal dural ring. And also when you cut the distal dural ring on the medial side, you will enter the medial venous space, so there will be brisk bleeding from the medial venous space. And when you remove, you see this arachnoid over the cistern which is intact here in the Meckel's cave. V1, V2, V3. Greater petrosal nerve, underneath is the carotid artery. At the margin is the superior petrosal sinus. We saw that when you remove this piece of bone, which is the Kawasai's posterior medial triangle, you can ligate the superior petrosal sinus and cut open the dura. Till you remove the bone, you will not be able to ligate the superior petrosal sinus because it's tightly applied against the petrous ridge. So again, this is just layer wise dissection of the cavernous sinus. First remove the dura propria, then remove the thin layer of dura which covers, that is the periosteal dura which covers the lateral wall of the cavernous sinus. Then once you remove the venous spaces, you enter the actual cavernous sinus. So if I did this step also, if you cut the trigeminal nerve and lift it above, you see the margin of the cavernous sinus. So the Meckel's cave, the upper 1/3 and middle 1/3 junction, the cavernous sinus extends till only the upper third of the Meckel's cave. Only the first division of trigeminal nerve is in the cavernous sinus. The second division is outside the cavernous sinus. It's not inside the cavernous sinus. So all tumors which arise in the Meckel's cave are not cavernous sinus tumors actually. All tumors which arise from the dura of the clinoid process are not cavernous sinus tumors. So clinoidal meningiomas are extra cavernous, paraclival or extra cavernous, Meckel's cave or extra cavernous. Only when they follow the cranial nerves along the cavernous sinus, then they become true cavernous sinus tumors. Posterior superior venous space, anterior inferior venous space, petrolingual ligament. You saw the petrolingual ligament at the anterior end of the carotid canal underneath the Gasserian ganglion. As it crosses over the foramen lacerum, is a ligament which extends from the petrous apex, this is the petrous apex, to the lingual process or the sphenoid, and then once it passes under that, it becomes the cavernous carotid, and this is the posterior genu. Here is the sixth nerve. The first division, ophthalmic division, has been retracted, so you can see the sixth nerve, and this is a branch from the inferolateral trunk of the carotid artery. Posterior superior venous space, anterior inferior venous space. So again you see that V1, sixth nerve, which comes like this. This is the petrosphenoid ligament which goes from the petrous apex to the lateral edge of the dorsum sella. So this is Dorello's canal. You see the sixth nerve coming on the lateral surface of the carotid artery, and then the first division and the trochlear nerve, both of them cross the third nerve. They converge and cross over the third nerve as they enter the superior orbital fissure. Petrosphenoid ligament. So these are the margins: anterior margin, inferior margin, posterior margin, and the superior margin. We also talked about the ophthalmic artery. Origin is just above the distal dural ring and enters the optic canal within the optic sheath. It penetrates and comes out of the optic sheath once it comes out of the optic canal. And then when you remove the bone between V1 and V2, you enter the sphenoid sinus. Again between V2 and V3 you enter the sphenoid sinus and see the median nerve. If you remove it anteriorly, more laterally you enter the infratemporal fossa, and anteriorly you enter the pterygopalatine fossa. Between the roots of the zygoma, if you drill the bone, you enter the mandibular joint, temporomandibular joint. Behind the V3, parallel to the GSPN, if you remove the bone, you enter the petrous carotid canal. Lateral to that, you get the tensor tympani muscle. These are the 7th 8th nerves, geniculate ganglion, GSPN, and this is the continuation of the geniculate ganglion below the lateral semicircular canal in the tympanic recess. And what you see from the lateral side, if you see it from an endoscope through the sphenoidal side, you see the optic nerve, and you see the carotid at the level of the anterior wall of the cella. You see the carotid artery, the curve of the carotid artery, and this margin along the floor of the cella is the level of the distal dural ring. At the upper level of the optico-carotid recess underneath the optic nerve is the proximal distal dural ring, and this is the proximal dural ring. So this is the clinoidal segment of the carotid artery. This is the triangular space of the optic strut, broad posteriorly, narrow anteriorly. And you see the optico-carotid recess. This is the clinoidal segment of the carotid artery. The cavernous segment is parallel to the floor of the cella. So between the optic nerve and the carotid artery is the optico-carotid recess, which is nothing but the medial end of the optic strut. The optic strut separates the optic canal from the superior orbital fissure. The maxillary strut separates the superior orbital fissure from the second division of the trigeminal nerve. So this is what you see in the lateral wall of the sphenoid sinus. Below the second division of the trigeminal nerve is the lateral wing of the sphenoid sinus, which goes between second and third divisions of trigeminal nerve. So this is the corresponding medial side of what you see from the lateral side. So you see the distal dural ring, optic nerve. The dura has been removed from the medial wall of the cavernous sinus. This is the cavernous segment, and this is the petrous. So all the triangles you can see from the medial side within the sphenoid segment. You see the optico-carotid recess. This is the optico-carotid recess separating the optic nerve from the carotid artery, and also the optic nerve from the superior orbital fissure. Between the superior orbital fissure and the second division is the maxillary strut, which is the anteromedial triangle. Anterolateral triangle is the lateral wing of the sphenoid sinus. So the triangles, you have already heard about that many times. Oculomotor triangle, clinoidal triangle in the roof, supratrochlear triangle, infratrochlear triangle in the lateral wall, anteromedial triangle in the middle fossa, anterolateral triangle also in the middle fossa. Then you have the posterior lateral triangle, posterior border of V3 and GSPN and the middle meningeal artery origin, foramen spinosum. So if you drill in this area, what do you get? You get the eustachian tube and the tensor tympani muscle lateral to the GSPN. If you drill underneath the GSPN, you get the petrous carotid, which continues like this under the Gasserian ganglion, goes under the petrolingual ligament and enters the cavernous sinus. So it is safe to drill in the most medial aspect of the petrous bone if you identify the margins of the carotid artery, the cochlea, and the internal auditory meatus. Internal lie of the internal auditory meatus is here. These are the two paraclival triangles. This is the inferomedial paraclival triangle, fourth nerve origin sixth nerve or sixth nerve entry point, fourth nerve entry point, and the posterior clinoid prominence. So this is the true wall of the posterior cavernous sinus wall. The inferolateral paraclival triangle, again sixth nerve entry point, fourth nerve entry point, and the first vein to enter the superior petrosal sinus. In the center of it is the porus trigeminus. So these are the two paraclavus triangles. So the same thing is enumerated. When you want to open the cavernous sinus and reach a particular thing, you have to know where is the lesion located. So that will determine your, when you want to see the posterior bend of the intercavernous artery or the clinoidal segment or the anterior bend of the cavernous artery, then you have to plan your approach accordingly. So all this is for the dorsal carotid ophthalmic artery aneurysms, for example, or clinoidal segment of the clinoidal meningiomas. You have to do an anticlinoidectomy to satisfactorily deal with those lesions. Posterior bend of intracavernous meningohypophyseal trunk is exposed through the infratrochlear triangle. Now these surgeries have become obsolete with interventional radiology for CCF. Nobody does these surgeries anymore. Middle fossa, you can enter the sphenoid sinus as already told, or the infratemporal fossa. And Cavernous is for dealing with the mesial aspect of the petrous bone. You have to do that in tumors only in petroclaval meningiomas, because the bone is not eroded in petroclaval meningioma and the origin is from the dura covering the petrous apex and the adjacent clival process. The advantage of doing an anterior petrosectomy in petroclaval meningiomas is you can devascularize the meningioma first. That's the whole idea of doing it. Otherwise you can do it from a CP angle approach also, where you have to remove the tumor completely before you come to the vascular supply of the tumor.